tuberculosis in the new millennium. Essential anti-tuberculosis drugs. There are three properties of anti-tuberculosis drugs: bactericidal activity, sterilizing activity, and the ability to prevent resistance. The essential anti-tuberculosis drugs possess these properties to different extent. Isoniazid and rifampicin are the most powerful bactericidal drugs active against all populations of TB bacilli. Rifampicin is the most potent sterilizing drug available. Pyrazimide or pyrazimide and streptomycin are also bactericidal against certain populations of TB bacilli. Pyrazinamide or pyrazimide is active only on an acid environment. Streptomycin is bactericidal against rapidly multiplying TB bacilli. Against rapidly multiplying TB bacilli, ethambutol and thiocetazone are used in association with more powerful drugs to prevent the emergence of resistant bacilli. Table 1 shows the essential anti-tuberculosis drugs and their recommended dosage. WHO, World Health Organization, discourage the use of thiocetazone because of the risk of severe toxicity, in particular HIV-infected individuals. It should be replaced by ethambutol, especially in areas where HIV infection is common. Thiocetazone may be used in combination with isoniazid with low prevalence of HIV infection when financial circumstances preclude the use of ethambutol. Standardized regimes. The choice by each country of a limited number of standardized regimens should be based on the availability of financial resources, efficacy, effectiveness, and applicability in the current health system network and population distribution mobility. Standardized regimens have the following advantages over individualized prescription of drugs: reduce errors in prescription, their therapy, reducing the risk of development of drug resistance, facilitate estimates of drug need, purchasing, distribution, and monitoring, facilitate staff training, record costs, facilitate regular drug supply when patients move from one area to another. Standard category regimens and recommended standardized treatment regimens. Treatment regimens for TB have a standard code. Each anti-tuberculosis drug has an abbreviation shown in this table as shown here. A TB treatment regimen consists of two phases: an initial phase and a continuation phase. The number before a phase is the duration of that phase in months. There are several possible regimens. The regimens recommended in each country's NTP depend on the country's budget, access of patients to primary health center services, qualifications of health staff at a peripheral level, and current best medical practice. The regimen recommended for each patient depends on the diagnostic category for each patient. Table 2 shows alternative regimens for each diagnostic category, which can be used in various circumstances and in certain subpopulations. Natural TB programs should decide the most appropriate regimens to be followed at national level. A treatment regimen in special situations. In pregnancy, a woman should be asked whether she's pregnant before she starts TB treatment. Most anti-tuberculosis drugs are safe for use in pregnancy. The exception is streptomycin, which is ototoxic to the fetus and should not be used during pregnancy. A pregnant woman should be advised that successful treatment of TB with a recommended standardized regimen is important for successful outcome of pregnancy. Breastfeeding. Breastfeeding women who has TB should receive a full course of TB treatment. Timely and properly applied chemotherapy is the best way to prevent transmission of tubercle bacilli to her baby. All anti-tuberculosis drugs are compatible with breastfeeding. A woman taking them can safely continue to breastfeeding. The baby should be given prophylactic isoniazid for at least 3 months. Beyond that time, with the mother is considered to be non-infectious BCG vaccination of the newborn should be postponed until the end of isoniazid prophylaxis. Oral contraception. Rifampicin interacts with oral contraceptive medications with a risk of decreased protective efficacy against pregnancy. A woman receiving oral contraceptive may choose between two options while receiving treatment with rifampicin. Following consultation with a clinician, an oral contraceptive pill containing a higher dose of estrogen, 15 gram, may be taken, or another from contraception may be used. Liver disorders. Isoniazid, rifampicin, and pyrazamide are all associated with hepatitis. Or of three drugs, rifampicin is least likely to cause hepatocellular damage, although it is associated with cholestatic jaundice. Of the three agents, pyrazinamide is the most hepatotoxic. Patients with the following conditions can receive the usual short course chemotherapy regimens provided there is no clinical evidence of chronic liver disease, hepatitis, virus carriage, past history of acute hepatitis, or excessive alcohol consumption. However, hepatotoxic reactions to anti-tuberculosis drugs may be more common among these patients and should therefore be anticipated. Established chronic liver disease. Patients with liver disease should not receive pyrazamide, also isoniazid plus rifampicin plus 1 or 2 non-hepatotoxic drugs such as streptomycin and ethambutol can be used for a total treatment duration of 8 months. Alternative regimens are 9-RE or SHE in the initial phase, followed by HE in the continuation phase, with a total treatment duration of 12 months. Recommended regimens are therefore 2 CHRA slash 6HR9 RE or 2 SHE slash 10 HE. Acute hepatitis. Acute viral hepatitis. Uncommonly, a patient may have TB related or TB and concurrently acute hepatitis unrelated to TB or TB treatment. Clinical judgment is necessary. In some cases, it is possible to defer TB treatment until the acute hepatitis has resolved. In other cases, when it is necessary to treat TB during acute hepatitis, the combination of SE for 3 months is the safest option. If the hepatitis has resolved, the patient can receive a continuation phase of 6 months isoniazid or sunizid and rifampicin 6HR if the hepatitis has not resolved. HSE should be continued for a total of 12 months. Renal failure. Isoniazid, rifampicin, and pyrazinamide are either eliminated almost entirely by biliary excretion or metabolized into non-toxic compounds. These drugs can therefore be given in normal dosage to patients with renal failure, patients with severe renal failure should receive pyridoxine and pyridoxine with isoniazid in order to prevent peripheral neuropathy. Streptomycin and ethambutol are excreted by the kidneys, where facilitate are available to monitor renal function closely. Streptomycin and ethambutol may be given in reduced doses. Thiacetozine or thiacetazone is partially excreted in the urine. However, since the margin between a therapeutic dose and a toxic dose is too narrow, patients in renal failure should not receive this drug. The fastest or the safest regime for patients with renal failure is 2HRZ/4HR.